Um, my audio video is clear. Let me know that, please. Hello, everyone. Welcome to Crown Edge. Please let me know once you join and we can start. Anyone? Any students, whomsoever available over here, let me know, am I audible and visible, and can we start the meet? Okay, so I got the reply. So today we are going to discuss the physiology INI CET July questions 2021. So these are the recall based questions. Okay, there can be some bias in the options also and the recall also. So don't worry about that. Okay, just the important thing is that we're going to learn the concepts behind it. Okay, so I'll try to make it very crisp, and let's start with the first question. Okay, so in the first question they ask about the RMP in myelinated nerve fiber is mainly due to. So remember, always and always remember, the RMP over here, they're not asking about action potential, they're not asking about action potential, they're asking about resting membrane potential. And no matter what, which cell they ask, nerve fibers, muscles, any cell, remember the ion that is important for your RMP is always and always potassium. It is always and always potassium. Now, why this thing happens is that, remember, there are some things which are important. First thing important is the concentration gradient. Okay, so you must be knowing that what is concentration gradient. Somewhere the concentration or the amount of a particular ion will be more, somewhere it will be less. Okay, so we know that we do have two compartments in the physiology, right? Either the compartment, the cell membrane divides the compartment. Outside the cell membrane we call it as extracellular fluid, right? And inside the compartment we call it as intracellular fluid. Okay, so in the intracellular there can be some ion which will be higher in concentration. For example, so let's take an example of potassium. So it is higher in the ICF, right? And what about the cations? These are cations, right? So what are the cations which are high in ECF? They are your sodium, magnesium, and calcium. Okay, so these are the cations which are more and less in the another compartments, one another, right? What about anions which are carrying the negative charge? So remember, the phosphates and the proteins are more in the ICF, and the chloride and all other are more in the ECF. Okay, so mainly you have to remember the potassium here, the phosphate here, the sodium here, and chloride over here. Okay, at least remember these four things. Okay, so now what is the next thing? So first we discussed about concentration gradient. Okay, so what is the next thing that is important for the which decides the RMP? So remember that so the next thing, first thing was concentration gradient. The next thing which is important for RMP is your electrical gradient. Electrical gradient. Now what is that? So because remember, the cell membrane is semi-permeable. The cell membrane is semi-permeable, right? That means it is like a guard. Okay, it will allow some and it will not allow some of the ions inside or to go outside. Okay, so it is like a gatekeeper. The cell membrane is like a gatekeeper. It is semi-permeable. It is not permeable to all the ions. It is permeable to only some ions. So which are the ions which are permeable fully? So remember, it is the only, potassium is the only ion which is permeable fully. and we just learned that it is more in ICF, right? So what is going to happen? Obviously, it is going to move outside into the ECF. Now, look over here. It is containing positive charge. So if positive charge go outside of the cell, what is going to happen inside the cell? If it is leaving, positive ion is leaving the cell, definitely the negative charge will be there inside the cell. Okay, and that's why the RMP is almost always negative. Most of the cell, that is 99% of the cell. Yes, there are some exceptions, but for now just remember that the RMP of most of the cell is negative. Why? Because the permeability to the potassium is very high, right? And the concentration gradient is more inside the cell, so that's why potassium try to go outside of the cell, which is containing positive charge, so which is going outside the cell. That's why it is create, if it leaves the cell, inside the cell it will be negativity, and that's why the RMP becomes negative, more and more negative. So similar question was asked 3 to 4 years before, that in AIMS, that RMP of the cell is near to which ion equilibrium potential. So near to equilibrium potential of which ion. So remember, if they ask you about the near to, so remember the near one is the chloride, the answer becomes chloride. But if they ask it is because of or it is due to, if they are asking, then the answer become potassium. So don't get confused. So RMP of any cell is especially the nerve cells, whether it is myelinated or unmyelinated, it is near to chloride. But if they ask it is due to, chloride is not permeable fully, so that's why it is not mainly because of the chloride, it is because of the potassium, but near to the chloride. Why is it so? Because remember, the RMP of neurons especially, it is how much? It is minus 70 millivolt. The question is already asked, so mark it star mark, right? So it is minus 70 millivolt. Okay, so the RMP of potassium ka equilibrium potential is around approximately minus 90 millivolt, and chloride ka the concentration or the equilibrium potential of that ion is minus 70 millivolt. So you can see it is near to the chloride, but it is not because of the chloride. Okay, so that's all about this question. I hope you understood. Okay, so just while going forward, just note down some important equilibrium potential or RMPs. Skeletal muscle, for skeletal muscle we already discussed that in the lecture. So skeletal muscle ka it is minus 85 millivolt, right? For cardiac muscle it is, yes please, how much? For cardiac muscle it is minus 90 millivolt, and for smooth muscle, important one, just 4 ones. Okay, for smooth muscle how much it is? It is minus 50 millivolt, minus 50 millivolt. So I hope you understood the question. If any query is there, we'll take it later on. Okay, let's move on to the next question. Pheochromocytoma is a tumor of which of the following? So remember, pheochromocytoma is hormone secreting tumor. So hormone secreting tumor. Okay. So you'll say, ma'am, hormone can be secreted by any of these. But remember, it is the tumor which is secreting catecholamines mainly. Okay. So whenever you remember pheochromo, so just remember chromo word over here. Why I'm saying so? Remember chromo word over here, because C for catecholamines and C for chromaffin cells. Okay, so C for chromaffin cells, and we already discussed pheochromocytoma also in the lecture, and chromaffin cells also, right? So the chromaffin cells in the adrenal medulla, so chromaffin cells obviously they are present in the adrenal medulla. Okay, and this is the tumor of chromaffin cells. That means the chromaffin cells are proliferating on the larger number. So what is going to happen? They are going to secrete large amount of catecholamines. And what are the catecholamines? Your epinephrine, norepinephrine, and dopamine. Okay, so what this epinephrine, norepinephrine, and dopamine they are going to do, remember, they activate your sympathetic system, which we learn in the nervous system already, right? So if a larger amount of these catecholamines are released, what is going to happen? The person becomes very, very active, known as hyperactive stage. So the person becomes very, very hyperactive. Okay, so his BP will be higher. So what can be the symptoms? If they give the clinical questions, especially in the INI CET, they give the clinical questions. So the person will be hypertensive, he must be sweating, the heart rate will be higher, or you can say the dopamine causes nausea, vomiting, and diarrhea kind of feeling. So that's why all these symptoms are going to be seen in the patients of Phiochromocystoma. Okay, so all other things, thalamus, hypothalamus, medulla, these are the CNS organs, right? And they are nowhere involved in this epinephrine, norepinephrine, or the pheochromocytoma. Now, remember, the pheochromocytoma that we talk about is going to get diagnosed especially on the CT scan and via the biochemical test. How? What you're going to do? You're going to take a sample of the blood and you're going to check the levels of epinephrine, norepinephrine, and dopamine, right? And that is known as, when we check the levels, they are known as metanephrine test. So just remember that metanephrine word. Okay, so metanephrine, ephrine is there, so you'll easily identify that yes, this is nothing but the function of adrenal medulla. Okay, none other than adrenal medulla. Okay, so that is all about this question. Okay, so pheochromocytoma, how to remember? Just remember chromo. Okay, chromo means color. Why? Because this chromaffin cells look very colorful on the histology. Okay, so that's why just remember chroma or chromo. Okay, cytoma means, oma means tumor, cyte means cells, right? So it is a tumor of chromaffin cells. Okay, easy to understand, right? Let's go to the next question. Which vitamin cause deposition of methyl tetrafolate and folic acid deficiency? Okay, so this is a very tricky question that in the folic acid deficiency which is happening, and they're asking which vitamin is causing that. So obviously, if there is a folic acid deficiency, so folate cannot cause that. Okay, that is ruled out. Okay, vitamin B6, that is pyridoxine, that is also not related to it, and vitamin K is also not related to the folic acid. Obviously, you can use the exclusive method. That means if you know some relation, you can go with that option. Okay, so in the megaloblastic anemia, we know that it is because of the vitamin B12. It is because of the vitamin B12. Just remember one name for this. It is known as methyl trap hypothesis. Now, what is that? Now, methyl is there. Methyl is getting trapped because of the vitamin B12 deficiency. Vitamin B12 deficiency. Okay, so if there is vitamin B12 deficiency, this methyl folate is going to get trapped up. Okay, so, and that's why it is going to lead to folic acid deficiency. Folic acid deficiency. So look over here. Look in this diagram. So I hope you can see this. So whenever the folic acid goes inside, ultimately it is going to convert into tetrahydrofolate. So it is going to convert into tetrahydrofolate. Okay, so once it is converted into tetrahydrofolate, what is going to happen? If the B6 is present, it is going to get methylene tetrahydrofolate, right? But we are not related to that. What we want is 5-methyl tetrahydrofolate. And which is important for that? look over here. The important over here, the vitamin over here is the B12. B12 is very, very important over here. Okay, so if the B12 deficiency is there, this reaction will not happen. This reaction will not take place. Okay, so again, and this is ultimately important for nucleic acid synthesis. So remember, the folic acid and vitamin B12 is important for nucleic acid synthesis. That means the synthesis of, yes please, what two things? The nucleic acid, that is your RNA and DNA, right? RNA and DNA, and that's why these two things are important. But if there is vitamin B12 deficiency, this tetrahydrofolate cannot directly be converted into methyl tetrahydrofolate. Okay, so that's why whole this thing is it will not be there. Okay, and that's why the DNA methylation will not be there, and that's why what is going to happen? There will be, yes please, so there will be what is going to happen if that those things are not there. So functional, this deficiency is actually, even if you give the supplements to of the folic acid, what is going to happen? So look once again in this diagram, what is going to happen over here? If you give the food folates, that is going to convert into 5-methyl tetrahydrofolate. Actually, they only just showed the reverse direction, but this happens in this direction also. Okay, so tetrahydrofolate will be formed, but this is not going to happen if the vitamin B12 is not there, right? So that's why what is going to happen if the vitamin B12 is not there? Ultimately, there will be something known as functional folic acid deficiency will be there. You need not to remember all these things. Just remember two words: methyl trap hypothesis, functional folic acid deficiency. Now, what is that? If the vitamin B12 deficiency is there, I'll just write def for deficiency. Okay. So what is going to happen? There will be decrease in methionine synthetase. Now, what is this now? Synthetase. This is the coenzyme. This is the coenzyme which is vitamin B12 dependent. Okay. So this is the vitamin B12 dependent enzymes, you can write, which is required to convert the actual methyl tetrahydrofolate into tetrahydrofolate. If the tetrahydrofolate is not formed, the folic acid cannot be used. Cannot be used because we have to remove the methylated form into tetrahydride form, right? So that's why, remember that is going to decrease the methionine synthase, and that is going to decrease the folic acid. Okay, so folic acid deficiency will be there. Easy, just remember this, that vitamin B12 deficiency is there, so methionine synthetase deficiency will be there, and that is going to lead to deficiency of folic acid. The levels will go low, below normal levels, and that is going to create the folic acid deficiency. But remember, the methyl tetrahydrofolate will be increased inside the body. Why? Because the food dietary intake is already there, right? It's just that methyl tetrahydrofolate is not able to convert into tetrahydrofolate. Okay, simple format. Okay, so that's why the over here the question says deposition of the methyl tetrahydrofolate is there. Let's move on to the next question. Thalamus does not act on. Remember, we already know what is the primary function of the thalamus. We learned in the lecture already that what is the primary function of the thalamus. Yes, please. The primary function of the thalamus is to relay the information that is coming from the motor pathways and sensory pathways. Okay, so its primary function is to relay the information, that is, you can say motor or sensory information. or you can say signals, okay, which are going to where? Cerebral cortex ultimately. Okay, so this is the primary. Now in sensation, all general sensation like touch, pressure, vibration, all those will be there, right? And in the special sensations like taste, vision, and everything will be there, hearing. Okay, but remember, the olfaction is the only exception. The smell, it directly goes to the cerebral cortex with your first nerve, that is olfactory cranial nerve. Okay, so it directly go without any relay. So olfaction goes without any relay to where? To the cerebral cortex. So that's why thalamus does not act on the olfaction, that is smell. Okay, so that's why the thalamus is nowhere related to smell. Now there is one more new theory that thalamus is involved. It is not acting, it is involved. Some theory, new theory says that the cerebral cortex, from the cerebral cortex, once it is processed, the smell is processed inside my brain, that it is sweet smell, it is pungent smell, or it is very the smell of the perfume of my crush. Okay, so what is going to happen? Once my brain knows that yes, that is that smell, so later on from the cortex, it may go to thalamus, it may goes to thalamus, but the thalamus is not directly related to it. The information is already processed, it is already in my brain. So that's why the answer over here becomes olfaction. The answer over here becomes olfaction, right? So the option is A, we know that. So what are the other functions of thalamus? Yes, it helps in temperature regulation, alertness. Why alertness? In the lecture we already discussed that the RAS system, reticular activating, the name itself suggesting that it is activating you, right? So get stimulated. Reticular activating system, that is known as RAS system, which is present in our brainstem. So this RAS system gives the alertness, and it does give the signals to where? To the thalamus. Okay, so the thalamus also help in the alertness. Yes, it does. Okay, regulate sleep wake up cycle. So the sleep wake up cycle, it is the cycle which is known as circadian rhythm. So remember, the thalamus is also, there is 24 to be precise 25 hours of clock in our brain which is feeded. Even if you are there, even the blind person, you can see he can know what is the time. Okay, the birds, they know what is the time, whether it is day, whether it is night. How? Because their thalamus is also there, which is helping them in the regulation of sleep. How? With the help of this circadian rhythm, our internal body clock, that is known as our internal body clock, which is definitely giving the signals to the thalamus. Okay, then other functions like sexual behavior of a person, right? That is also sleep, also the temperature, also then various other functions like hunger, whether you are hungry or not, whether you are thirsty or not. Okay, so all these things will be relayed into the thalamus. Just one exception, that is olfaction. That sensation is not relayed in your thalamus. So answer over here, because they ask not, right? So answer over here becomes, yes please, the option A. Okay, let's move on to the next question. Function of aldosterone. So what is the function of aldosterone? We know that it helps in sodium retention. Okay, how? Just give me a minute, we are going to that. But remember, indirectly, it also influences the water retention. So answer, the best answer over here is option C. The best answer over here is option C. They do not wrote anything directly or indirectly or both, something like that. Okay, if they wrote function of aldosterone to directly, or the aldosterone act directly on absorption of, then the answer becomes only sodium. But remember, indirectly it also act in the water retention. It also act in water retention. Let's see how. Okay, so look over here, the zona glomerulosa. There are various layers of your adrenal cortex. Okay, so one of that is your, yes please, what thing, one of that is zona glomerulosa. Okay, so we know zona, there are three layers. How we remember? GFR, right? That was the mnemonic already given in your notes, right? So G for glomerulosa, which is going to secrete mineralocorticoid, right? That is nothing but your aldosterone, right? Then fasciculata, fasciculata, right? That is going to give what thing? That is going to secrete glucocorticoid, okay? And then there is a reticularis that is going to release your sex steroids. Okay, so remember GFR, very very important. Okay, so what is going to do, the aldosterone is going to do is that electrolyte balance, it is going to maintain electrolyte balance. How? Suppose this is the cell, suppose this is the cell, this is known as principal cell or P cells. Okay, the detail is there in the lecture, but just discuss it quickly in the crisp manner, that what it is going to do. Once the aldosterone act on it, once the aldosterone is going to act on it, what it is going to do? It is going to absorb the sodium from the tubule, right? And it is going to remove the potassium over there. Why is it doing so? Because remember, we absorb one positive ion to maintain the electrical balance in our body. What is going to happen? Either we have to absorb one negative ion with it, or we have to secrete one positive ion. And that is how the body is very very brilliant in its work, that it absorbs the sodium and it releases the potassium. Okay, it also helps in the absorption of chloride and water, since the water follows sodium. This is the rule that we already learned, right? So always and always in the renal system, remember, or in the body also, water follows sodium. So remember, the sodium is the crush of this water, right? So water has immense crush on the sodium. So wherever the sodium will go, the water will follow the sodium. And that's why I said that the aldosterone is going to absorb both the sodium also and water also. Why that happens? Any physiological role? In remembrance we can remember like that, but remember, the sodium is highly osmotically active particle. Okay, that means it is going to increase the osmolarity of your blood. Okay, but we know that body needs homeostasis or the balance of it. If the osmotically active particle is increased, that means your solute is increased. To maintain, what we are going to do, we need to increase the solvent also. And what is your solvent? Your solvent is nothing but your, yes please, water. Okay, so remember, as the osmotically active particles sodium get in, the solute levels are increased, the water level is still low. So what the water does, water get absorbed automatically and it increases the balance of the osmolarity. It maintain the balance of osmolarity. So remember, we increase both sodium also, that is osmotically active particle, and water also. So what its importance? So whenever the blood pressure goes low, this aldosterone will be secreted more and more, and hence via aldosterone the BP will be back to normal level via increasing the blood volume, by increasing the blood volume. So BP goes low, the aldosterone will be secreted. Aldosterone secreted, it asks to kidney to absorb more and more sodium and water. The BP comes back to normal. Okay, so that's how brilliantly these guys are working. Okay, Now, where exactly in the nephron this act? This act on distal convoluted tubule, and also remember it act on the collecting duct. It act on the collecting duct. It act on two cells, that is P cells and I cells. I cells are intercalated cells. Intercalated cells. In the intercalated cell, what it is going to do? In the intercalated cells, you do have something known as hydrogen ATPase or H plus ATPase. Okay, so it is going to secrete more and more hydrogen ions. Okay, so that's the function of I cells. Okay, so that is all about this question. So I hope this is clear to you guys. What is the function of aldosterone and how it works? So remember that aldosterone, yes, directly act on the sodium, but indirectly also act on water also. So sodium follows the aldosterone action, and the water follows the sodium action. Easy. So that's why it acts on both and it absorbs both. So retention of both sodium and water. Let's move on to the next question. Carbon dioxide is carried in the blood in what format? So remember, the carbon dioxide is absorbed in three format. What are those three format? So first of all, remember, in the dissolved format. Okay, so from tissue, some directly goes into the blood without binding to anyone, and they swim towards your lung. Okay, so from tissue towards your lung. So how much it is? It is only 10%. Remember, it is only and only 10%. Okay, the second one is with the help of bicarb. So some carbon dioxide binds to the bicarb, right? Or in the form of bicarb, it is going to go towards the lung, and that is important that it is 75%. 75% out of 100%, it is 75%. It is very, very, very important. So most of the question already come 3 to 4 years before that. Most common form of carbon dioxide carriage in the blood. So remember, most common, even if they ask most common, the answer will be the same, bicarbonate. The answer over here also, it is bicarbonate. Now, what is the third one? So remember, there is known as carboxyhemoglobin, but that is not carboxy. That is known as carbamino, amino hemoglobin. So I'll just write HP. Okay. So remaining 15%, that will be carried with the carbamino hemoglobin. Over here, they ask about CO2. Remember, carboxy means just one oxygen molecule. So that will be COHB. That means it is not carrying the carbon dioxide. It is carrying carbon monoxide. Remember. So what do you want? Carb amino hemoglobin. So what is carb amino hemoglobin? It is CO2HB. So CO2 bound to HB, that is your carb amino hemoglobin. But if you want to say carboxy, that means it is carbon monoxide. Okay, carbonate is not the form in which the carbon dioxide is followed, and there is no such thing as methyl carbonate in which the carbon dioxide is there. Okay, in the methyl carbonate there is no carbon dioxide. Okay, so remember, so over here there are only and only three formats present, either dissolved, bicarbonate, or carbamino, not carboxy. In the blood system also, in the lecture we discussed the difference between carbamino, reduced hemoglobin, the methyl hemoglobin, and various hemoglobins. Okay, so over here the yes, please. Option A, bicarbonate. So already 3 to 4 times the question is asked on this carbon dioxide transport or the oxygen transport. So remember, this is a very, very important topic. Okay, so let's move on. Okay, the next thing is muscle involved in inspiration. Muscle involved in inspiration. So muscle involved in inspiration is both diaphragm also and external intercostal also, we already discussed. Okay, pectoralis major does not include in the inspiration. Okay, why? Because they just ask inspiration, they do not ask about forceful inspiration. Okay, so that's why the answer over here becomes option C. Okay, so whenever we say just inspiration, so these two muscles are going to work. How much? Yes, please. We already discussed 75% contribution is of the diaphragm. Okay, and only 25% of the contribution is of your external intercostal. How to remember? I told you, go reverse, vice versa. Okay, in the inspiration, external intercostal will work. Okay, and in forceful, remember, I'm writing forceful, not the normal expiration. Okay, in the normal expiration, it is the recoil, it is passive, does not need any muscle. Okay, so just need to relax these two muscles, which happens automatically, right? How that happens, neural regulation, that we talked in lecture. Over here, just we are since we are having short of time, so forceful expiration, what in over here the x is coming, that means the internal, go reverse. Okay, x in, okay, internal intercostal is involved. Okay, so if they ask in, go with x. Okay, in never goes with in, so inspiration never goes with internal intercostal, it always go with external intercostal. Okay, so and same here, these two are important, so you have to balance each other. But remember, over here I'm writing forceful expiration, tidal expiration if they ask, or normal expiration they ask, then your answer might be none of the above, because we do not need any muscle to expire. For inspire, it's an active process, we require these two muscles. For expiration, we do not need any muscle, just we need to relax diaphragm and external intercostal. If they ask about forceful inspiration, yes, then another accessory muscles, they are going to help you out in that. Pectoralis major also comes. Okay, but not in the normal inspiration. Okay, let's move on to the next question. Breastfeeding is beneficial to child, not beneficial to mother. Okay, so now remember, it is beneficial to both. Okay, so that's why we say that the beneficial I should be there. Anyways, breastfeeding beneficial to child and beneficial to mother. Since they wrote over here, the examiners wrote not beneficial, so this becomes false statement. And yes, it is beneficial to child because DHA is there, right? Various immunoglobulins are there, colostrum is there, right, which is going to give the immunity to the child, and it helps in the growth and development. Various hormones, various immunoglobulins, various nutrients which are present in the mother's milk is not present in the outside milk or cow milk. Okay, or any formula, right? So that's why it is beneficial for the child, that we know of, right? But whether it is beneficial to mother or not, yes, definitely. Whenever the mother does the breastfeeding, what is going to happen in her body, there are two hormones are going to get released in the mother's body. One is the oxytocin and one is the prolactin. Okay, so oxytocin help in the ejection of the milk. Okay, and the prolactin helps in the production of the milk. So if they ask production of the milk is because of, then how you're going to remember? Remember P for P, right? P for production, okay? And X for ejection or exiting of the milk. I told you, okay? So X for X. So exiting of the milk, ejection of the milk is because of the oxytocin, and production of the milk because of the prolactin. But how that is going to help to the mother? So remember, these two hormones does very important thing. What is that? It is they're going to promote the uterine contraction after the delivery. Okay, obviously the breastfeeding start after delivery, right? So uterine contraction, so how that is going to help? This uterine contraction going to squeeze the blood vessels of the uterus. Okay, and that's why the mother will not bleed a lot. Okay, so that is the protective phenomena given by the nature, right? So once the mother start breastfeeding, these hormones will be increased, and they are going to stimulate more and more to the uterine contraction, right? So two things happen because of that. What are the two things? First thing is that uterus come to the normal size. Uterus is enlarged whenever the baby is growing inside the uterus. Now to become in the normal size, it must contract, right? So what happens is uterus returns to its, because of these two hormones getting released by the breastfeeding, returns to its normal size. Okay, and it decreases the postpartum, means after delivery. Partums means delivery. Postpartum hemorrhage. Postpartum hemorrhage. Remember, third thing, it also decreases, since the uterus is contracted, its mouth opening also contracted, so it also prevents the chances of UTI. Okay, it is also give the pressure on the bladder, and it also prevent the entry of the bacteria inside the uterus. Okay, so that's why, remember, it also prevent or decreases the chance of the UTI. Okay, it is going to decrease the chances of infection, decrease the chances of postpartum hemorrhage, and this size of the uterus becomes normal after this. Okay, now what is the another benefit of the breastfeeding to the mother? The mother, remember, mother, whenever she breastfeed, obviously she is giving the nutrition to the baby. Okay, and she must be gain a lot of weight during her pregnancy, so it also help to burn more calories, approximately 500 kilocalories extra if daily per day, if she breastfeed regularly to a child, right? So helps to weight loss after birth of the baby. So that's why the mother who gets the breastfeed, it is important for her health also, and to get back to the normal shape also. So remember that it is very, very beneficial to the mother also, and for the child also. So that's why we promote the breastfeed to the child in every hospital. Okay, let's move on to the next question. Lung volume, which cannot be measured by the spirometer. Remember, the spirometer, that is the, let's see, we have the diagram over here or not. So spirometer is just a simple machine. Over here you can see the simple machine. In that, what we are going to do, in this, what we do is, we ask the patient to blow the air. First of all, we ask the patient to inspire completely, and then blow the air through the mouth, and we pinch his nose. Okay, so over here you can see the pinching of the nose is there, and we ask the subject to blow the air inside the spirometer. It's a meter which is measuring the volume of the air which is coming through its his mouth. Okay, so that's why what is going to happen, we ask the patient to blow inside the tube, right? And we are going to measure that inside the monitor. The monitor will analyze the volume and will give us the graph. Okay, so there are some volumes which there are some volumes which will be there inside the lungs, which will not come out even if you apply no matter how strong amount of force. Okay, so even if I apply a lot of force to expire fully, still, my lungs or my alveoli contain some volume which is known as residual volume. It is going to residual volume. It is going to be there inside my lung even after, that will be inside the lung even after forceful expiration. forceful expiration, and that is known as residual volume. So whichever capacity, what is the capacity? Capacity is combination of two or more volumes, right? So whichever volume which contains this residual volume, that will not be measured, because we are measuring the air volume which is coming out, right? If it is not coming out, we'll not be able to measure with the spirometry. Simple. So over here, the residual volume is given. Okay, so tidal volume, normal inspiration, normal expiration. If you ask the a person to inspire forcefully, then that will be known as inspiratory reserve volume. Okay, inspiratory reserve volume can be easily measured, right? So if you ask to breathe normally, you're going to only get 500 ml, around 500 ml of air inside that spirometer. Okay, if you ask the patient to inspire fully and then expire, you're going to get around 2500 to 3 liters, or 2.5 to 3 liters of extra volume, and that's how you're going to know that this is his IRV, or that is the measured. What we can do is, if we want to check the IRV, we are going to give the person with the jar in which the already measured volume of air is there, and we are asking him to inspire through the mouth. Okay, so we can measure that also. Okay, and expiration, yes, ERV, we ask the patient to if we ask the patient to expire normally, resting without any applying any force, then what we are going to get? We are going to get tidal volume. If we ask the person to expire forcefully by applying force, then we are going to get ERV. We discussed this in a lot of detail in the lectures also still, but there is some amount of air which is going to be there inside the lung even after force for expiration, that is known as RV. Okay, we cannot measure that because that is not coming out. Okay, so yes, we can measure the IRV, we can measure the ERV, we can measure the tidal volume. What is the vital capacity? If you combine the IRV, tidal volume and ERV, so IRV plus tidal volume plus ERV, so what you are going to get? The tidal volume. These three can be measured, right? So that's why the vital capacity can be measured also, right? So that's why we can measure the ERV, expiratory reserve volume, we can measure the IRV also, and to these two volumes, if you add the tidal volume, we can measure the vital capacity also. But I told you, what is the functional residual capacity? If you combine the residual volume with the ERV, okay, so functional residual capacity is the combination of these two things. You can see over here, it is the combination of ERV plus RV. I told you, whenever the RV is there, that is residual volume is there, we cannot measure that. So if we cannot measure the RV, we cannot measure the FRC. Okay, and the total lung capacity is nothing but the combination of all of this. So total lung capacity, if you see, what is the total lung capacity? Total lung capacity is nothing but all of these, but it also contains RV, so we cannot measure that also. But since the TLC is not given in your option, so answer over here becomes FRC, that is functional residual capacity. What is the funda to remember over here? Just remember that whichever volume or whichever capacity is containing the RV, that is residual volume, we cannot measure that with the spirometer. Let's move on to the 10th question. Gap junctions are present. What is the gap junction? They are simply a gate. They are simply a gate which is present in cardiac muscle, which are present in your cardiac muscle. Okay, so okay, we do not have the diagram over here right now. So anyways, so what are these gap junctions? So remember, this is, suppose this is one cell and this is another cell, or cardiomyocyte. Okay, cardiomyocyte. So cell number 1, cell number 2. Okay, in between them there is a junction. there is a gate or there is a junction which is made up of proteins, named connexin, already asked in your exams. So remember this. This is made up of protein connexin. If 6 such proteins come together, they make connexon. Just remember connection. Okay, so it is a Latin word for connection. So remember connexon. Okay, so connection. It is connecting two cells. Okay, it is kind of bridge between two cells. Okay, which two cells? Cardiomyocyte. What it is going to do, whenever you stimulate one cell, what is going to happen? Whatever ionic changes are going to happen in the cell, they can directly go into the another cell without entering into outside environment. Okay, and that's why the changes or the response will be quicker, very rapid response. So what is the benefit of that? Remember, they are present in all the cells, and your ventricles are made up of thousands and thousands of cells. Okay, so but it contracts at same time, so almost same time. The all the cells will contract. These are myocytes, that means muscle cells, right? The heart is made up of muscle cells, that's why we call it as cardiomyocyte, right? So they contract, they have the property to contract. Okay, so whenever you're going to give the stimulus to one cell, the ionic changes will occur over here, and those ionic changes will be followed in second cell without the continuous stimulation in the second cell. So second cell does not require any stimulation. Even only one cell is stimulated, the response will be seen in all the cells. Similarly, over here also there will be a channel. There will be channel which is connected to next cell, right? Cell number 3. So such things are going to go forward, and that's why your ventricles contract at the same time, right? Though it is containing lot of cells. Okay, so that is known as functional syncytium. The heart is known as functional syncytium. That means a one functional unit. So though there are thousands and thousands of cells in the ventricle, right, but it acts as a one functional unit. Okay, so it acts in the unity, and that's why we get such a higher amount of force inside the blood, so that the heart can pump it throughout the body. Okay, so that is the benefit. And remember, it does not there in the skeletal muscle, that is not there in the neurons, or not even in the smooth muscle. It is only and only the gap junctions. That is, it is a junction which is having a gap, that is connection. Okay, that is only and only present in the cardiac cells, not in the any other cells. Next thing, intrinsic factor. Intrinsic factor. Now, the intrinsic factor, short form IF, it is secreted or produced by the parietal cells. This parietal cells, we already discussed in that GIT lecture also, that it is also known as oxyntic cell. It is also known as oxyntic cells. Okay, so one of the exams in AIMS exam, they ask about the oxyntic cells. So one and the same thing, remember. So this intrinsic factor is released by which thing? It is released by your parietal cells. Okay, so look in this diagram. This diagram is very important. What they given in the option, other options, let's see. Salivary gland, it cannot be secreted. The intrinsic factor cannot be secreted by any other cells. Remember, inside the body, it is only and only secreted via the gastric parietal cells. Okay, it cannot be in the ileum, pancreas, or salivary gland. They are not secreted. What they're talking about is the extrinsic factor. Now, what is this extrinsic factor? Remember, the extrinsic factor is nothing but your vitamin B12. So remember, very few people know this, that the extrinsic factor is a name given to a vitamin B12. in one of the exam they asked about the extrinsic factor, and the student came to us that you taught us the intrinsic factor, but what is the extrinsic factor? It is the name given to vitamin B12, nothing else. Okay, now you remember that. Okay, so what is shown over here is the salivary gland. So what happens is that it helps in this, the intrinsic factor. Just remember, look over here, that intrinsic factor is secreted by the parietal cells, which is also known as the intrinsic factor, or the cells are known as oxyntic cells. The parietal cells main function is to secrete the acid, that is HCl. But with that, the vitamin for the absorption of vitamin B12, the intrinsic factor is very, very important, right? We discussed this diagram in the lecture also, very importantly, right? So vitamin B12 is like a small child. It requires the protection. So in the salivary gland, the digestion should not happen over there. Enzymes are present in the mouth also. So heptocorrin is going to protect it. Okay, and then onwards in the gastric acid, from the gastric acid also the heptocorrin is going to protect it. Then later on, whenever it comes to the intestine, that is duodenum, this heptocorrin detaches from the vitamin B12, but still it requires the protection, right? Because vitamin B12 is absorbed in the terminal ileum, right? So the protection to the vitamin B12 from the intestine, remember, is given via your intrinsic factor. It's given via your intrinsic factor. So remember, the simple question is asked, so no need to go in detail. Remember, just remember, it is only and only produced by the gastric parietal cells, which is also known as oxyntic cell. Let's go to next question. A blood group, a group B negative person can receive blood from. So remember, there is a Landsteiner's law. Landsteiner's law, what the Landsteiner's law suggests? If the antigen is present, the antibody must be absent. The considerate antibody or the antibody must be absent. Otherwise, the antigen antibody reaction will happen. We do not want that in the body, right? And these antigens are present on the RBCs. So if the antigen is present and antibodies are also present, they're going to destroy our RBC, which we do not want. So if the antigen is present, antibody must be absent, and vice versa. If the antigen is absent, the antibody must be, yes please, present, because antigen is absent. So if that antigen comes in our body, the antibody will react to it, because this is not our cell, right? This is some foreign cell. Okay, so that's why it should be destroyed. It should be destroyed. And because of this law, the B negative person will be having, negative means he is talking about RH, rhesus antigen. There are two antigen. First is H antigen, and then is the RH antigen. The H antigen that can be of A type or B type. Whether it is present or absent, depending on that, the blood group will be there, right? And which H antigen is present, right? And there are antigens which is the H antigen, and the H antigen is nothing but your RH antigen, and A antigen or B antigen. Okay, so if look over here, if the over here the antigen is present, antibody must be absent. Okay, so A antigen is present, A antibody is absent, but B antibody is present because there is no B antigen. Okay, vice versa happens over here. Over here the B antigen is present, so that's why they call it as group B, right? But the antibody A is present. Why? Because antigen A is absent. What if the both antigens are present? None of this antibody will be present because of the Landsteiner's law, and vice versa. If none of the antigens are there, both the antibodies will be present. So if we talk about B negative blood group, that means he is going to have B antigen, right? And he is not going to have H antibody. So either he can receive the blood from B negative blood group or from the O negative blood group. Okay, so O blood group, let's write. So B negative or O blood group. Okay, I think the time is getting over, but just give me 5 minutes, we can complete it off. Okay, so remember, even if O positive blood is there, that means he is going to contain the H antigen, and we do not want that also, right? So that's why we are going to give him the blood O negative. Remember, if you give any of this blood, B positive, it is going to contain H antigen. Then O positive, it is going to contain the RH antigen, right, or H antigen. And if you give AB negative, it is itself containing the A as well as B antigen. Okay, so that is going to react to the blood of the recipient. Okay, and that's why we can only and only give O negative. If they would have given B negative, definitely we can give the B negative blood or O negative blood. Okay, we do not want any foreign antigen to introduce to the patient, so that's why we can give either the same blood group or O negative blood group. Let's move on to the next question. Conversion of activation of prothrombin to thrombin is achieved by. This is factor 2. Remember, this is a factor 2 which comes in common pathway. So if you come and see this diagram over here, we already discussed that in the lecture also, blood lecture, coagulation cascade, right? So there is extrinsic pathway and intrinsic pathway. What is the pathway which is extrinsic? Factor 12, 11, 9, 8 and 10. Okay, and over here tissue factor or tissue thromboplastin, that is factor 3, factor 7 and then to the factor 10. Okay, then to the factor 10 finally. Remember, this factor 10, once it is activated either from the extrinsic or from the intrinsic, that is going to activate your prothrombin and convert your prothrombin into thrombin. That is, yes please, factor 2. That is factor 2. And ultimately, this factor 2 is going to convert the factor 1 into its active form, that is fibrinogen to fibrin. We already discussed that in a detail. So remember, over here they are asking about this factor, that is factor 10, the factor 10. Okay, so the answer over here is very simple, factor 10. Factor 10. They're asking about activation of factor 2, which is factor 10. Let's come to the 14th number question. That is, patient came to the OPD with a history of feeling dizziness, vertigo-like sensation, on sudden standing. That means he were either sitting or lying down. Then he suddenly stand up. What is going to happen? The blood will be, because of the gravity, the blood will be pulled towards the leg veins, and the blood to the brain will be reduced. Okay. When the vitals are checked, the BP found to be low, that is 90/68. Normal BP is 120/80, right? This is very, very low BP. Normally, which of the following compensatory mechanism they asked to maintain the BP? So over here, what is going to happen? This BP is falling down. So we have to increase the BP. We have to, for compensatory mechanism, we have to increase the BP. To increase the BP, what should we do? Either we should activate sympathetic system, right? We should inhibit the parasympathetic system to the heart. Okay. Now, there are one more receptors which are very, very sensitive to this BP. That is your baroreceptors. We discussed that, right? Baro means pressure. And which pressure they are talking about? Obviously, the blood pressure. And I told you the baro means brakes. B for B. I told you in the lecture, and we discussed the question on this also. Remember, B for B, that is baroreceptor. B for B, that is brakes. They act as a brakes to BP. So B, B, B. Okay, they act as a brakes to BP. So if the BP is already down, we have to inhibit this brake. Okay, so we have to inhibit the baroreceptors so that the speed of the BP will increase, right? The rate of the BP will increase. And which are these baroreceptor? One is present in the carotid sinus and one is in the aortic sinus. Okay, so these are the two sinuses. So let's see what are the options. First option is increase parasympathetic outflow. I told you we have to increase the BP. So we have to decrease the parasympathetic. So this cannot be the option. Decrease the firing rate of carotid sinus nerve. So yes, we have to decrease the firing of baroreceptor so that brake will be released and the BP can increase. The speed of the BP can increase, right? So this is the answer over here. If we increase the sympathetic system, that is going to increase the heart rate, not decrease the heart rate. Okay, and decrease the sympathetic, no, we have to increase the sympathetic outflow. Why? We have to increase the BP of the patient for activating the compensatory mechanism. They ask for the compensation. What should happen to normalize the patient that they are asking? So answer over here becomes option B. Okay, so we discuss clearly in the CVS system that, okay, so whomsoever joined this lectures, it must be helpful, and I'm very happy whomsoever got this question right. Okay, next question. In Kazan's disease, joint pain is due to, last but not the least question, only 2 to 3 minutes. Okay, so remember the Kazan's disease is because of the nitrogen. What is this Kazan's disease? Whenever the deep sea divers are there, so this is seen in deep sea divers. Okay, so whenever someone goes in very, very deep sea, what is going to happen to the pressure, environmental or atmospheric pressure over there? The atmospheric pressure, as you go below the sea level, it is going to increase. It is going to increase. So once the atmospheric pressure is increased, the solubility of nitrogen is increased. As you increase the atmospheric pressure, the nitrogen solubility inside the blood is going to increase, and because of that, what is going to happen is that this nitrogen will go and deposit somewhere in the joints also, in the brain also, in the lungs also. If this deep sea diver come quickly on the surface, sea surface, what is going to happen? All this nitrogen which is already dissolved in the blood will not be able to come out, and it will form a bubbles, and these bubbles will block the arteries. This nitrogen bubbles will block the arteries, and they are going to give the joint pain. Okay, so they are going to stuck in between the joints. So suppose this is my bone. Okay, this is my one bone and this is my another bone, right? So what is going to happen? They are going to form a bubbles over here. So the joint movement, whenever you do a movement of the joint after coming on the sea level, that will be very, very difficult. These bubbles are there which are not able to come out. Why? Because he came very quickly on the surface, right? And the nitrogen bubbles do not get any time to go and dissolve back and come out through the respiratory system, and that's why they get accumulated over here. Okay, and that is going to cause the joint pain. Also, if they stuck inside the brain, that can cause stroke also. If they block the arteries of heart, that is going to cause myocardial infarction also. If they block the arteries of lung, that is going to cause pulmonary embolism also. So a lot of complications. Okay, so just remember, in the Kazan's disease, which is happening in the deep sea divers, is always and always because of the nitrogen. Kazan's, N for N, nitrogen. Okay, it is not because of the oxygen, not because of the carbon dioxide, and helium is very, very thin gas. It can easily come out even in the low pressure. Okay, so this nitrogen is very dense gas, and that's why it requires high pressure to get back outside. Okay, which is not going to happen in this case, and that's why the answer over here is nitrogen. I hope you liked the session. I hope the lecture notes which were there were very, very helpful in INI CET. Whomsoever got many questions right, and whomsoever are still trying for the next INI CET, all the best to them. And let me know in the comments how do you feel the class was, right? And I guess that's all for the class. and the time is also over, right? So